Inaugural session of 2021 for the Wellbeing series, and couldn't think of a more appropriate topic to start with, really based on the unprecedented challenges that we have faced and really been augmented to a foundation of what we were calling the physician burnout and distress. And to lead us in this discussion, we have an esteemed panel of guests that have been really organized by Dr. Julie Adams. She will be introducing the speakers. So Dr. Adams is professor of orthopedic surgery at the University of Tennessee College of Medicine, Chattanooga, and practices at Erlanger. She's had a very prestigious career. She completed her MD from the University of Alabama and then completed a residency in orthopedic surgery at Mayo Clinic, as well as a Master of Science in Orthopedic Research. She went on to do her fellowship in hand surgery at the Philadelphia Hand Center. She has many publications and book chapters. We're very excited when she volunteered to serve on our towards the wellness efforts at our institution, especially representing the Department of Orthopedic Surgery with her colleagues, and is currently the chair of the Ethics and Professionalism Committee at the American Society of Surgery of the Hand. If I had to go through her complete bio and CV, I think we would take quite a bit of time. So with that, I just wanted to welcome Dr. Adams and thank her for really organizing this session, which is really going to be very informative and also in response to a lot of feedback that we got from meeting with each of you. A few housekeeping items. Please sign into the chat your attendance only to Kim Judd. Kindly mute your audio with respect for the speakers as they're speaking. You can type your questions at the end of each talk in the chat box, and we will address the question and answers at the end. So with that, Dr. Adams, I'm going to turn it over to you, and thank you.
Thanks, Dr. Panda, for that kind introduction, and thanks to all of you for your attention. Burnout is real, it's widespread. Hand surgeons are generally pretty happy people. We get to sit down when we operate. Most of our patients get better, but a third of hand surgeons still endorse symptoms of burnout. And so we've assembled a panel of hand surgeons to talk about burnout and some of the symptoms of it. But this is not just applicable to hand surgeons, it's, I think, applicable to all specialties. We know the manifestations of burnout are maladaptive, and the alternative is becoming resilient, developing better coping skills, and being a resource to others. Dr. Don Lee from Vanderbilt will be speaking about burnout and cynicism. Dr. Felicity Fishman, I apologize, her picture came out pixelated off your website, Lissy, is talking about resources for reaching the disruptive physician and about bullying. Alton Barron, who is an author of the Creativity Cure and is affiliated with NYU Langone and Dell Medical School, is going to talk about finding joy in everyday life. Scott Lifchez, who served with me on the Ethics and Professionalism Committee and is a resource in terms of self-care and resilience from Johns Hopkins, who is Associate Professor of Plastic and Reconstructive Surgery, is with us today. And then finally, I'm going to talk about environmental concerns. So with that, Dawn, if you can go ahead and share your screen.
Okay. How are we doing there? Can we see it?
Perfect.
Okay. All right. So let me talk a little bit about burnout. And this is normally about an hour talk that I give, but I'll try to condense it down into a few minutes. So burnout was first, the term was first coined in the 1970s by Herbert Freudenberger. And it's a state of mental and physical exhaustion caused by one's professional life. And in my experience, it's been pretty insidious, and I'll talk about it in a little bit. And I won't get into this too much because Scott's going to talk about this a little bit, but here are the components of burnout: emotional exhaustion, depersonalization, and low sense of personal accomplishment. So you're trying to constantly live up to your own demands and expectations and those of others, including your job, family, and friends. There's a decreased capacity for compassion, empathy, and caring dwindles. And then there's a low sense of personal accomplishment where you think nothing that I do seems to matter. It is a consequence of the work situation. Throughout this talk, I have a bunch of books that I reference to. And if you're interested in these types of topics, I know this is being recorded, you may want to look up some of these books. So you feel like you're batting your head against the wall. Your expectation level is dramatically opposed to reality. You're trying to reach an expectation which you might not be able to get. And then there's trouble on the way. And healthcare professionals are pretty prone to this. They thought there's 3 levels. It depends on where you read. There's different levels of burnout, but mild levels are probably what we endure all the time, which is mild signs and symptoms, up to chronic signs in level 3, where you may develop physical illness. In this 2020 survey, 42% of physicians are burned out, 32% of orthopedics. And interestingly, the highest rates were urology, neurology, and nephrology. Gen Xers tend to have a higher level of burnout compared to millennials and boomers. And the top 3 contributors are bureaucratic tasks, spending too many hours at work, and a lack of respect from administrators, employers, colleagues, or staff. I think this last one's actually relatively important too. What about severity of burnout? Boomers, when they do get burnout, tend to be affected a little bit higher than millennials and Gen Xers. And women tend to have a higher level of burnout compared to men. I know there's some women residents that are out there listening to this. And the theory on this one is that not only do you have your expectations at work to do your professional life, when you get home, you still have the expectations at home to be a mom and a wife. So why are physicians burned out? If you look at this article from Leiter and Maslow, it's a combination of workload, a sense of lack of control, insufficient reward, the lack of feeling of community, the lack of fairness, and conflicting values between you and what you think management wants. So here's my experience with burnout. So for some reason, around 2016, I started keeping track of my late cases. By late cases, leaving the operating room by 6 p.m. or later. That's not just me leaving. The residents are usually staying behind and staying a little bit longer. So the residents were also staying later. And then in a particular bad week around June of 2018, you could look at the times that I was leaving the operating room. And it was around this time we moved from to a new surgery center, which I wasn't a part of at the time, but we were at an old surgery center, and I had 1 to 2 rooms in a fairly efficient surgery center twice a week. And that went down to 1 inefficient room in the main OR. So most of my cases were being scheduled as add-on cases, and this might sound familiar to some of you. So I still had about 50, 60 cases a month, majority of them being add-on cases. And I clearly felt a lack of support from my leadership. And I think this is also a key for a lot of people. So how to deal with burnout? I think you do need to develop a self-care protocol, but it highly varies from person to person, and you have to figure out for yourself how you're going to deal with it. In this national survey, exercise was a fairly good reason, and I think that's a good coping mechanism. Talking to family members and close friends, also a good mechanism. Isolating yourself from others is not a good coping mechanism. Sleep is important. Listening to music, eating junk food, drinking alcohol, binge eating, those other things are not good coping mechanisms, and we'll get into that a little bit. Interestingly, 64% of physicians who thought they had burnout or depression did not plan on seeking care for burnout. We do have a program here at Vanderbilt. You probably have a program there. If you have symptoms of burnout and you think you need help, then I would certainly seek out the help. So what's working for me? I kept it as a simple acronym, SIMPLE: spiritual, inspirational or motivational, mental, physical, lifelong learning, and emotional. So the acronym simple. By spiritual, I'm talking about aligning yourself with something larger, becoming engaged, determining priorities. Inspirational, having a sense of purpose, defining goals, defining success and legacy. Mental is self-examination or self-awareness, cultivating the right mindset, and cognitive behavioral therapy, which I'll get into a little bit. Physical is fairly obvious: rest, sleep, exercise, proper diet. L is lifelong learning, investing in your mind and self-reflection. And emotional, which is fostering relationships, providing mentorship, controlling stressors, and defining happiness and well-being and gratitude. So under spiritual, I don't know if you heard of this guy here, Vicktor Frankl. He was an Austrian neurologist and physiologist. He survived 4 concentration camps. And he found that the people who died early were the ones that gave up hope. So lack of hope and meaning was the demise of a lot of people. He said, life is never made unbearable by circumstances, but only by the lack of meaning or purpose. And his meaning and purpose to survive the concentration camp was to go back to Austria and teach about his logotherapy, which is the type of therapy that he devised, and also trying to meet up with his wife, who was in a different concentration camp. Unfortunately, his wife did not survive the concentration camps. He said, life is not primarily a quest for pleasure or a quest for power, but a quest for meaning. Forces beyond your control can take away everything you possess except one thing: your freedom to choose how you will respond to the situation. You cannot control what happens to you in life, but you can control what you feel and do about what happens to you. And I think the sooner we kind of realize this, you understand that there are a lot of things we cannot control. And the only thing that we really can control is ourselves and our response to things. Volunteerism is a way of becoming engaged. We started a local program here, and Julie and you guys are probably going to do something similar. Determine your priorities, which for most of us is some form of family, faith, and friends. Terry Canale, who's a past president of the Academy years ago, he said, I lived my life to regret that I've spent too much time on my career to the neglect of my family, which is fairly telling. So we do have a sense of purpose. We, as physicians, have great purpose. We do worthwhile work, and we make a difference, and we need to understand to appreciate the difference. That's my daughter, who's a first-year medical student here at Vanderbilt. Albert Schweitzer says, I don't know what your destiny will be, but one thing I do know: the only ones among you who will be really happy are those who have sought and found how to serve. Next is inspirational. Define your goals, determine your legacy, define success, and have a sense of purpose. So goals have to be realistic and meaningful for personal achievement. They can't be too easy, but they also can't be too difficult. If it's too easy, they're seldom appreciated. They give little personal satisfaction and frequently are not worthwhile. So what are your goals in life, and how do you plan for your own personal legacy? Some people may have heard this acronym for SMART goals, and you can see what SMART goals are referencing there. I don't know if you thought about your definition of success. There's a lot of books out there on happiness and success. And this is one of the best ones that I've seen. Success is peace of mind that is direct result of self-satisfaction and knowing that you did your best to become the best that you're capable of becoming. So this is regardless of the types of achievement that you've achieved in life. So it's a matter of just doing the best that you can. Under mental self-examination, cultivating the right mindset, and cognitive behavioral therapy. So Socrates says that the unexamined life is not worth living, but Saul Bellow talks about if Socrates says the unexamined life is not worth living, but the over-examined life makes you wish you were dead, giving the alternative, I'd rather be living. So in other words, you do want to do some self-examination, but in moderation. You don't want to get into rumination, which is concentrating on all the bad things that you've done. And so this happens also with burnout. I don't know if you've heard about Angela Duckworth and Grit and Carol Dweck and growth mindset. You may want to read about this, but a growth mindset is the belief that the ability to learn is not fixed. Now, cognitive behavioral therapy is, so cognition is a thought or perception. So you're having a thought or perception right now. You're saying, all right, this talk is pretty good, or this talk really stinks, but that's a cognition. So cognitive behavioral therapy tries to change cognitive distortions and behaviors by improving emotional regulation and helping you develop coping strategies. Bibliotherapy is self-therapy, which is through reading or listening to audiobooks, but it's also positive therapy. And they found that for moderate depression, bibliotherapy, self-therapy is as effective as formal therapy. And it is and fairly long-lasting, but just like any therapy, you have to keep going. It's not a read one book and you're done. You have to keep going with it. So if you're feeling problems with depression or things like that, you ought to look into bibliotherapy and cognitive behavioral therapy. So under the physical, sleep is obviously important, but sleep deprivation, which all the residents get, is consistent with mild prefrontal lobe dysfunction. So they recommend 7 to 9 hours of sleep. Exercise and proper diet is important. The other is lifelong learning, investing in your mind, always be learning and acquiring knowledge. These are a bunch of books that if you're interested in these types of topics that you might want to get into. I use a lot of Audible. You need to know what kind of learner you are. Are you visual, oral, verbal, or kinesthetic? I don't really have time to get into that, but audio allows me to listen to books that during times that I can't be reading a book, like commuting or walking. Tons of apps out there, audio programs. This one's kind of an interesting one on the bottom right, Masterclass. If you haven't heard about that, you may want to look it up. If you are interested in the topic of burnout, go ahead and read about it. On your emotional, take time to develop outside interests, take time for yourself, foster relationships. This is a good book on burnout and the resilient physician. There's a bunch of ways to replenish the self. Don't really have time to get into all of those. The Gallup poll says that people are happiest on days when they spend 6 to 7 hours socializing. And John Wooden says you cannot live a perfect day without doing something for someone without the thought of repayment. Control your stressors. You need to analyze frustrating situations, develop a time management strategy. Here's an example. If you want to try to get to an event and whatever that event is, and you can't make it, you become very frustrated about not being able to make it. Well, the problem is not outside factors that have caused you not to get to that event. The problem is that you didn't plan ahead of time. So that's a way of minimizing the stressors that you have. Rumination is self-criticism, and the other thing is break the cycle of relativity about comparing yourself to others. At Vanderbilt, sounds like what you're doing down there in Chattanooga. We started a Vanderbilt Orthopedic Wellness Committee. We are trying different sessions for orthopedics to see if that will help patients. For us, we all have, or majority of us have scribes, which has really helped in terms of just paperwork. Read this book, Sean Acor, on the happiness advantage, the principles between success and happiness. This is another good one, Martin Seligman on Flourish. He's the father of positive psychology, and he talks about PERMA, positive emotions, engagements, relationships, meaning, and accomplishment. So have your life align with something bigger than yourself. So in summary, keep it simple: spiritual, inspirational, mental, physical, lifelong learning, and emotional. And hope I didn't take too long. Sorry about that.
Thanks, Don. That's great advice. Our next speaker is Lizzie Fishman, and she'll go ahead and start sharing her screen. She's going to talk about bullying in medicine and surgery, an important topic.
All right. We can see the slides.
Looks great.
Excellent. All right. So as Dr. Adams mentioned, today I will be talking a bit about bullying, which may not be something that you've heard about in the past. It certainly wasn't something that I was super familiar with in all of its details until I did a deep dive for this talk originally. But today we will talk about the definition of bullying, the prevalence in medicine, why it's a particular problem in medicine, and how do we eliminate it now that we've identified it. So what is bullying? Bullying is a systematic abuse of power defined as aggressive behavior or intentional harm doing by peers that's carried out repeatedly. And it typically involves an imbalance of power, whether that's actual or perceived, between the victim and the bully. It's again characterized by intimidation, humiliation, aggression, emotional abuse, or psychological mistreatment that's repetitive in nature. And commonly it's verbal. And this can be humiliation or intimidating in terms of the words. There are multiple different types of bullying. Verbal, as I mentioned, is the most common. Intimidation can have to do with your work performance. There can be work sabotage. It can be retaliatory in nature, or it can be pervasive throughout the institution, in that the institution actually fosters an environment that has unrealistic production goals, forced overtime, and singles out those that can't keep up. So who's doing the bullying? About 70% of the time, the bullies are male, and 30% of the time, the bullies are female. But the typical target, regardless of the bully, is a female. 2/3 of the time, it's coming from your boss or your supervisor. So in the medical setting, that's generally a superior physician or an administrator. But about 1/3 of the time, it's coming from your coworkers. So potentially other residents, other colleagues at the attending level, as well as potentially nurses or other staff. When it's a manager or superior that's doing the bullying, it's often an abuse of power. You may get a negative performance review that was not justified. Perhaps they are denying your time off. They're threatening to fire you or demote you. And when it's your colleagues, it can be a bit more subtle. It can be in the form of gossip or work sabotage, or potentially just continued criticism. So what's the difference between bullying and discrimination or harassment? We hear a lot about discrimination and harassment. Discrimination is an adverse action taken against a person because of a protected characteristic or activity. And harassment, again, is when you're treating someone poorly because of that characteristic or activity. Bullying, on the other hand, is this unreasonable behavior that is risky and damages health and safety, but it's not due to the fact that somebody is a part of a protected group or characteristic or activity. We also know that discrimination and harassment are illegal or unlawful. There are federal and state laws that cover workplace discrimination and harassment, but the definition of bullying is a bit more slippery. It's wide and broad, and so therefore it's very hard to define, and there haven't been laws that have been advanced to address this. There's a group called the Workplace Bullying Institute, and in 2014, they did some research to try and figure out what environments basically foster these scenarios in which there can be increased bullying. And they found that bullying occurs quite frequently in environments that are stressful, that change frequently, heavy workloads, have unclear policies potentially about employee behavior, have poor employee communication and relationships, as well as employees that may be bored or worried about their job security. And I think we can all look at this list and find at least a few things that are probably applicable to your residency or your work life at this point in medicine. So why is it the perfect crime in surgery? Surgeons value hierarchy. Sometimes we think that other specialties are potentially afraid of us. And throughout medicine, there's this sort of pervasive unspoken code of silence where we really don't like to speak up against each other, partially for fear of retaliation and partially because we just don't like to sort of point out other people in this fashion. The other issue is that bullying is invisible in terms of the outward appearance, especially when it's verbal or psychological in nature. It doesn't leave a mark. Trainees are often targets of bullying because of this hierarchy, and then often this is perpetuated because of the fact that you may have a role model that was the bully, and therefore you emulate that behavior. Often in the educational setting, the bully thinks that they are helping the trainee. So they're motivated by a desire to improve this trainee's performance. But in this scenario, the intentions are irrelevant. When we use harsh pimping and humiliating questions as our teaching tool, this is not effective, and it's actually a form of bullying. And often these educators are protected by the hierarchy as it's the way they've always taught. In Australia, they took a look at where the bullying was happening, and they looked at business outside of medicine as well as within medicine, and they found a much higher rate of bullying in workplaces in medicine as opposed to outside of the hospital. They found about 50% of the people who responded reported being bullied. About 70% said they witnessed bullying, whether or not they were actually bullied. And only about 20% of the people said that they actually made a formal complaint. And in this scenario, the medical situation, the attendings were most likely the source of bullying that was reported. So why does it persist now that we've identified it? One thought is that we see the aggression and the bad behavior, but it's being performed by a role model. And therefore, in our brains, we normalize this bad behavior. And because they could be a recognized person within our specialty, the behavior goes unreported and then it perpetuates. The other issue, as I mentioned before, is that there are no state or federal statutes against bullying. So because it's not illegal, it's hard to crack down upon this issue. Few institutions even have policies, regardless of the law. And we all know that we have anti-harassment and anti-discrimination policies, but even though bullying is 4 times more prevalent, it's not illegal. So the Healthy Workplace Bill was established by that Workplace Bullying Institute that I mentioned previously. And they're basically trying to pass federal legislation so that we have a more uniform approach to bullying. And you can see the states in purple there all have state legislature, and the blue states have training mandates in regards to bullying, but all of those gray states have nothing in regards to bullying on the books. So as I go through this list of specific examples, I would like you to think about your own life and potential scenarios that you've had in your training, whether in medical school or residency. So other more subtle examples of bullying include persistent attempts to belittle or undermine one's work, setting impossible deadlines, excessive performance monitoring, being humiliated in front of your colleagues on a repetitive basis, making inappropriate jokes or destructive innuendo, having important information withheld, as well as the more obvious of physical violence. In an educational scenario, we can think about it in particular at an academic conference when we use humiliation instead of constructive learning techniques. Having expectations or demanding productivity that's unrealistic in the setting of residency, I think, can be a common one that we can think about. And then M&M conference has historically been a key scenario in which bullying has occurred, where instead of using medical errors or failures as a learning opportunity, we've used them as opportunities for shame. So most bullying in this scenario, bullying of nurses, is not flagrant. It can be a lot more subtle. Certainly when we think about surgeons bullying nurses, we think about throwing instruments in the OR or something very blatant of that nature. But it can actually be as passive as not answering a page or a phone call, subtle condescension, or potentially just repetitive sarcastic remarks. And the issue here is a domino effect. So when we bully those around us, such as a doctor bullying a nurse, then the nurse bullies another nurse. You can have nurses bullying interns and on and on. And really, this does not create an environment that's conducive to patient care, and you can increase the rate of medical errors. We know that bullying is associated with suboptimal health and poor job satisfaction. It's associated with anxiety and depression, and it affects patient outcomes, and as I mentioned, can potentially increase the rate of medical errors. Bullying makes the victim feel a sense of loss of control and this sense of shame, which makes it challenging for us to do our job if we're the victim of bullying. We know that medical students have a problem with this as well. About 50% of medical students report that their self-confidence drops during medical school, and part of this is due to being bullied and shame. And it's gone so far as the ACGME in 2017 actually having a set of program requirements to try and address this. So now that we know that bullying is present and probably at a higher rate than we have previously acknowledged, how do we cope with this bill? And we know that at the state to try and address disruptive behaviors. Professional societies, we need to urge them to take a position on this. So historically, there's been quite a bit of tolerance of disruptive behavior, and we really need national medical societies to develop a comprehensive position statement on disruptive physician behavior so that we can have unity in this topic. Within the workplace, we need to urge our hospitals to have uniform standards, to require potentially civility training for people who are not participating in these standards, and have real consequences for bullying. Our healthcare leaders should assess our environments to make sure that we don't have that list that I spoke about earlier that fosters increased rates of bullying. So we want to try and avoid excessive workloads, role conflict, ambiguity. We want to have coworker support, and we want to try and minimize the outward competition. But these are challenging things just to have as a document. We really need to change the culture. You can't just write down a list of things and assume that other people will start to follow them. So the change has to start at the top due to the hierarchical nature of medicine and hospitals. And we want to try to create an environment of openness, honesty, respect, and cooperation. As educators, we want to be more empathetic. We want to try to create a culture of kindness and respect. We want to reframe failure as a learning opportunity as opposed to an opportunity for shame. We should try to use constructive feedback more than destructive feedback, as this is a better way to express our learning topics. And if you're a victim of bullying, we urge you to speak out, to realize that you're not alone, to try and realize that it is not you, and report your bullying so that you can break the cycle. So again, some general recommendations would be to adopt a policy of zero tolerance for this disruptive behavior, to create a culture that focuses on attaining goals by enabling individuals and groups to maximize their potential, to recognize and reward behaviors that demonstrate collaboration and high respect for interpersonal ethics. So we know now that bullying is much more prevalent in medicine and in surgery than most of us previously were aware. It continues to be underreported, which makes the problem continue to perpetuate. We need big cultural changes in order to break this cycle. And we should consider changes that we can make at all levels, all the way from individually up to the national level. Thank you.
Thanks, Dr. Fishman. That's a great analysis of the problem of bullying in medicine. Our next speaker is Alton Barron. He's going to be talking about finding joy in everyday life. And Alton, you can start sharing your slides, please. I think that it's really interesting understanding the issues associated with teaching and folks being well-meaning, but sometimes our actions can have implications that we don't desire. So thank you for that, Dr. Fishman. Dr. Barron?
You see it?
We see it.
All right. Eureka. All right. Thank you. Thank you all. And I love being part of this group. I derive so much from it. And there is overlap, as you see, as we get farther down the line, there's overlap between what Felicity was saying as well as what Don is saying with this. And so let's move on. Positive psychology, as Don mentioned, was really invented, fathered by Seligman, but it's predated by Maslow's work. And it's essentially a scientific study of the strengths that enable individuals and communities to thrive. It's founded on the belief that we all want to lead meaningful and fulfilling lives, and we want to cultivate that which is best within ourselves. And that will enhance our, as Freud said, love and work, but also play. Freud didn't talk as much about play, but it is important. If you do nothing else from this talk, please jot down and plan on taking this 15-minute survey. It's the VIA survey. It's a character survey, and it looks at all the different components of character, and you can see them listed there. This is a slide from the VIA character survey. It's both fun and informative, and it can inform greatly your own wellness and sense of purpose in knowing a little more deeply yourself and what makes you tick. The principles of positive psychology have been, can be organized and have been as PERMA, which is positive emotion, engagement, relationships, meaning, and accomplishment, all with the goal of helping you manage stress and health and well-being, and increasing the amount of happiness. None of us can be happy every day, but the goal is to increase your moments, the number of happy moments that one has. Character is so fundamental to our sense of autonomy and purpose and the way our lives really move through the days. It's defined as mental and moral characters of an individual, but Ralph Waldo Emerson said, the great thinker said, character is higher than intellect, and I would agree. And this actually overlaps with what Felicity was saying about bullying. And one needs to always be trying to work out of one's strengths. This allows for flow to develop, which is a higher state of productivity and joy. And if we can do that, then we're going to find that we are experiencing more virtue and more authenticity in our lives, and that's obviously much more rewarding. Intrinsic motivation is greatly dampened by burnout, all the things that Don was talking about, and intrinsic motivation is so important. Self-determination is related to autonomy, relatedness, and competence, and all those, I think all of you listening, you are very, very started out very autonomous and very related and extremely competent. That can become a slippery slope. We have to make sure that we are fostering and protecting our intrinsic motivation for our optimal growth and our well-being. The human connectivity can be dampened so much by the bullying and harassment and so forth, but our mentors, our own mentors are a great source of connection, but we need to, especially as we get deeper into the medical field and beyond, we need to serve as mentors and role models. And we can find this deepness of connection, as Don pointed out, people who care for us and for whom we care and tend to. And relationships are number one. The longest running study on happiness out of Harvard showed absolutely relationships are number one. Women who were recovering from breast cancer had higher success rates when they were going through that with the support group. People carrying a backpack up a heavy incline, if they were walking with a friend or a companion, felt that the trip up the hill with a heavy backpack, which was much less debilitating. Creativity is fundamental to our well-being. And we have to strive to have moments of creativity and periods of creativity. My wife wrote the Creativity Cure, and I learned much from her in this regard. The divergent thought versus convergent thought. Convergent thought is when you're trying to find a single answer to a problem, and that's easy. We do that every day. We try to focus in on the right medication, on the right diagnosis, exactly the one answer. But divergent thought is the idea where you're trying to explore multiple solutions, and that will generate much more creativity, more ideas, and the brainstorming concept. And it's very, very important not to pigeonhole ourselves into just convergent thinking. Spontaneous experiences help so much in the creative process, and culture, exposure to culture has been widely shown. More and more medical education institutions are exploring culture and imbuing the students, especially with cultural art and photography and other forms of expression, and it's critical. Altruism, I think everyone probably on this call and this practices altruism daily. It absolutely does provide us greater sense of well-being, happiness, health, and longevity. And emotional and behavioral compassion, empathy, of course, for a well-lived life is important, but we have to make sure that we are being empathic with ourselves and that we are being compassionate with ourselves for our own, because if we are not living or striving for a well-lived life, we're not going to be able to imbue others with that. And we cannot do that if we are overwhelmed by tasks. And that is where burnout, from where burnout derives, of course. And you'll get multiple clues as to how to emphasize that and to achieve that. Nature, there is a surfeit of good scientific study to show the importance of nature. It elevates mood, it increases dopamine release, it decreases anxiety, and it improves cognitive performance. Kids who were actually about to take a test, half of them were allowed to go out into the gardens and walk around right before the test. The other half were left sitting in the room. And the kids by far who went out into nature before the test scored consistently higher. It's a simple concept. Gratitude, journaling, especially if you can keep a journal and daily just jot down a couple of things that you were grateful for that day. It seems trivial, but it's not. Gratitude blocks toxic emotions such as envy, resentment, regret, and depression, and can destroy our happiness. And if we've been bullied, well, okay, that needs to be addressed, but also you can offset that by thinking about some of the things that were positive that day as well. Don talks about Vicktor Frankl, who's an amazing thinker. He wrote Man's Search for Meaning. And one of the most important things that I would add to what Don said, well, he said that between stimulus and response, there is a space. And in that space is our power to choose our response. in our response lies our growth and our freedom. And he was very adamant about, obviously being in 4 concentration camps, losing his wife, but always having that hope until he lost her. He felt very strongly that meaning can derive from both suffering or happiness. And so it's just important to keep that in mind and know that some of the torment and torture we may find ourselves in, the title of this talk was Everyday Life. I don't even know what everyday life means now. None of us do really with regard to the pandemic and other issues, but we do know that we are day to day caring for people and taking care of them, and we need to take care of ourselves as well. And that brings us to self-reliance. Self-reliance is critical. Autonomy, the idea that we must have agency, must have rely on ourselves. And I love this little cartoon. Where did you find that? I've been searching for it everywhere. Well, I created it myself. And so that's the way we can do that by focusing on some of the little things, going back to that character survey. Think about, take a moment and think about the little things that bring you immense pleasure, such as pets, gardens, playlists, baking, crafting. One simple thing might be to start repairing things that are broken in your home. That's a great way to stimulate your somatosensory cortex and find meaningful handles. All right, thank you so much for having me, and we'll move on to Dr. Lifchez.
Thanks, Alton. Our next speaker is Scott Lifchez from Johns Hopkins. And Scott, can you upload or share your screen for your slides? Thanks, Scott. Scott, you may be muted.
Wouldn't be a true Zoom if we didn't say that.
Seriously, you'd think I'd be better at this by now. All right, we're going to try that one more time. Okay, can everybody see my slides now?
Yes.
Okay, and here. All right. So as Alton mentioned, I've gotten a lot out of being a part of this group and sort of both what I learned preparing my talk and hearing everybody else's talk. I'm going to focus a little bit on sort of the what can you do in a day-to-day moment. There's been some of that in each of the talks. I hope you'll find it useful. I also have a little light reading list at the end that I hope will be useful to the group. No disclosures relevant to this talk. And then just here's what I'm going to talk about. So just to briefly touch on what burnout is, since it's been mentioned, again, emotional exhaustion, depersonalization, decreased sense that you've accomplished anything, and there are these escalating set of consequences of it: fatigue, inefficiency, errors, including medical errors, and then in its worst form, suicide. Probably all of you have seen some of those alarming characteristics, particularly among physician groups. Unfortunately, burnout is getting more prevalent among us as doctors. These are actually in retrospective order. Tate Shanafelt writes a lot about this. And in one of his publications in 2014, more than half of physicians met criteria for burnout, which was up from his similar survey only 3 years earlier. As compared to 2009, the American College of Surgeons said only 40% met criteria. And the Physician Work Life Study, which is now 20 years old, but was landmark at its time, also noticed something that was mentioned earlier, that burnout does seem to occur more frequently in women. Just to briefly talk about the measurement of burnout, the Maslach burnout inventory is one of the more common tools utilized to measure it. It's a fairly simple scale that is used. The first 2 sections, burnout and depersonalization, ask about a number of emotional activities and a bunch of activities, and then say how often have they happened in the last week. And these first 2 sections are kind of framed in the negative. The more you have of them, the more burnt out you are, the worse you are doing. Now, what I find interesting, and I'd even argue useful about the Maslach burnout inventory, is there's this third section, section C, the personal achievement section, which is kind of the inverse. What are the things that are helping me? What are the things that are protecting me? Here, a higher score is actually protective against burnout. I'm feeling full of energy. I accomplished something. And again, the scale of how often have these things happened in the last week. And sort of stepping off of this kind of gets us to well, we have all of these stressors. We have all of these things making our life difficult. What can we do about it, both in terms of the tools we sort of started out with and how we can build upon this? We use the term resilience, and it gets overused, but to put it in a straightforward and hopefully practical term, resilience is the ability to recover from stressful situations and negative events, but it doesn't just mean live through it. It doesn't just mean survive. It actually means growth. It means becoming stronger in the process. It means developing strategies and skills for dealing with future negative, stressful events. So you didn't just live through it. You didn't just get through the day, but maybe you're a little bit better prepared for tomorrow for having done so. Now, resilience has a number of different dimensions that contribute to it. There are physical, there's emotional, mental, and spiritual. Again, a lot of these things have been talked about in the earlier presentations, and coherence is kind of where each of us stand as individuals, how we use each of those facets in our desire to be and our ability to be resilient. Now, there are things that we can do that promote resilience and attitudes that we can have that will make it easier for us. Now, this is a long list, so I won't go through all of it, but some of these hopefully are fairly intuitive when you look at them. Some important ones, at least ones that I found important, accepting personal boundaries. This is where I have to say, no, I can't take on this additional thing. Recognizing when change is necessary, again, adjusting the environment. Dr. Adams is going to talk a little bit about that in the next talk. There are also activities that you can do that promote resilience. Some of them are obvious: leadership, leisure time activities, building relationships, talking about job-related stress. So again, a lot of these have been talked about before, but these are all things that each of us can do. And you don't have to do this full dozen-item laundry list, but maybe find a few of them out there. Find the ones that work for you. They can make a difference. Well, what about the greater systems that we work in? Well, there have been some efforts on this. The University of Rochester, now 15 years ago, introduced a medical school curriculum on mindful practice to promote resilience, even when people are starting as medical students. And the students who were there then are now even like mid-career attendings, let alone the medical students who are still getting this now. There are workshops for physicians in practice about self-awareness, about resilience, support groups. It's difficult. We're all really busy, and some of these take time to get there. Some of these take money to do. And not all of them are as good as other ones. Hopefully those of you watching our talk today are finding this useful to you, at least worth your hour. But those are some challenges in getting these done. I'm going to pivot just a little bit to talk specifically about self-care as a means of kind of achieving resilience and achieving mindfulness, which I'm going to talk about in the next slide. So what is self-care? It's a commitment to nurturing wellness, your personal wellness, your professional wellness. Again, some of the same things that we've talked about with resilience in terms of dimension. There's physical, emotional, psychological, and spiritual. And one of the best ways to deliver on this is something called mindfulness. Now, in my training program, we did a whole half-day webinar on mindfulness, and I'm going to try to compress it into about 30 seconds of one slide here, and I apologize, it really doesn't do it justice. But this is one of the ways that we can promote this self-awareness and resilience in us. To kind of briefly describe what mindfulness is, it's obvious things like paying attention. Well, that's sort of intuitive. Being on purpose, not just kind of going through activities because you've always done them or because they're sort of automated internally, but actually intentfully. I'm going to have a conversation with someone. I'm going to sit down and take a moment to breathe for myself. Being in the present moment. Again, I'm going to talk a little bit about more of being present. And then finally, non-judgmentally, I am not going to assess what I'm doing now as good or bad, but just simply, I'm going to do this. I'm going to do this for myself as a means of self-care. Being present. This is so much harder than it was a year ago. How many of us could have used Zoom as a verb a year ago, let alone Zoom as an internet tool? Zoom is awesome. Here, I'm in Baltimore, Maryland right now, and I get to talk to all of you, and that's pretty cool. However, I also had to be in an OR scheduling meeting immediately leading up to this, and I have to go to clinic as soon as I'm done. It's hard to stop where you were, make yourself be where you are, and then not be thinking about, and where do I have to go next? It's much harder to do now than it was even a year ago. The good news is, number one, we can train ourselves to get better at it, and number two, it does work. So here's the good news, getting back to mindfulness. As we practice this, as we take minutes for ourselves to do this, there actually are prospective journal published studies showing that we can decrease our anxiety, our depression, our anger, our worry, our stress, and increase joyfulness and gratitude, the hopefulness. There are even some medical studies that show you can make some chronic diseases a little bit better with this. Things like psoriasis, type 2 diabetes, rheumatoid arthritis, and ones that might seem more intuitive to you, like attention deficit disorder. One study on medical resonance showed that training in mindfulness reduced resident stress and burnout better than providing an equal amount of time of just free time. Hey, do whatever you want to do with this. So I'm going to take a breath at this moment and introduce what I think is a term that gets alluded to but not talked out specifically, something called self-compassion. We talk a lot about self-esteem, and self-esteem is important, but I'm going to define it to be distinguished a little bit from what I call self-compassion and talk about why I think the latter is maybe a little bit more useful, a little bit more valuable to us. So self-esteem is the global evaluation of self-worth. The challenge is outside forces act on this. Also, you can have too little self-esteem, but you can also have too much self-esteem. We've all interacted with people who certainly at least come off to us as arrogant and come off as too much self-esteem. Both of those are potentially bad things. Also, it can in some circumstances promote us to be denigrating, be non-supportive of others in the name of promoting our own self-esteem. Hopefully none of us are intentionally doing it, but it does still occur. And I want to contrast this with something called self-compassion. And in simplest terms, it's accepting oneself as one is, including flaws, without judgment. Mindfulness is a component of this. So we've talked about that a little bit. And it combats, self-compassion does, this false instinct of saying that self-criticism is the only way we're going to get better. The only way I will make myself better than I am is identifying the things in me that are bad and making them better or getting rid of them. And the problem with that is you are your own attacker. How do you defend yourself against you? And so thinking about it in this different frame of self-compassion can be a change for the better, can make you more effective at this. What does it do on your stress response? Well, when we turn the stress response inward again in a self-esteem, self-evaluative way, the fight response becomes self-criticism. The flight response becomes isolation. The freeze response becomes rumination. And again, these were mentioned in earlier talks. In contrast, self-compassion becomes self-kindness. The flight response becomes common humanity. The freeze response becomes mindfulness. Okay, I'm going to stop, but I'm going to take that as an opportunity to be present, to acknowledge myself and my environment and be where I am right now. Relationships can help with this. Don mentioned a lot of this in his talk at Alton. Pay attention to your social relationships, particularly the ones that support you, the ones that give you energy rather than take it away. Give yourself permission to say no on occasion. I don't have added energy to share with this. Self-care is necessary. Self-care is important. Self-care makes us better. It's not selfish, despite the fact that we may think of it this way. Okay, so now what do we do? So resilience does protect us when negative events occur. Some people start out with better skills, but you can teach it, you can learn it, you can get better at it and help yourself with it. Self-care is the primary way to improve resilience, physical, emotional, and spiritual. Again, mindfulness is a key component of this. And then finally, the concept of self-compassion, accepting oneself as one is, rather than exclusively self-esteem. I'm only getting better if I beat down what is bad in me rather than correct it. So self-compassion being the better, the more supportive, the more growth-oriented way to go and help oneself. I think I sent in my slides earlier. I also have some light reading for anybody else who cares to do it. And thanks everybody for your attention. I will unshare my screen.
Thanks, Scott. Tremendous information and some great ideas about how to endorse this in practical suggestions. So it's always a challenge to get my talk up. For the sake of time, I'll kind of run through this fairly quickly. My task is to talk about environmental concerns. Others have spoken about changing yourself, your attitude, confronting others, but what if we really have a responsibility to change our environment? to make it better for ourselves, our patients, the people we work with. Organizational culture and factors that lead to burnout is if you feel like you're not making a difference, you're not appreciated, work overload, there's no clear expectations, you have an unfair or abusive workplace. And social construct contributors have also been studied. These include the EMR, pushing buttons, focusing on the machine or documentation, not the patient or caring. The rat race, in which you start seeing patients as an RVU number or a case number instead of as a person. Depersonalization, when we are termed providers, not a physician or a surgeon. Potential shift labor, lack of respect for medical professions, lack of predictability, and again, unfair workplaces or lack of transparency. So what can be done? Dawn talked a little bit about scribes. The thing that has probably been most effective in my practice is dot phrases that educate the patient in the era of open notes, and also whoever sent me the patient. That means that instead of me documenting things and dictating the same thing over and over, I can do a dot phrase and spend the time actually talking to the patient instead of the computer. In terms of depersonalization, really connecting with your patients and seeing yourselves or your loved ones in them. Consider employment that supports your values and uphold the values that give our profession respect, and lobby to have your institution uphold those values. Consider volunteerism, as Dawn talked about, and remind the public of why we are physicians and why we are the trusted and expert individuals we are. What about respect? You know, I think our profession is subject to onerous oversight, lack of trust, trusting Dr. Google more than each of us because of bad actors. And we're highly trained professionals. We cannot be substituted, and we need to lobby the public to show our value. We need to show the professionalism and ethics that we all took an oath for. Institutional strategies that care for each other. At Mayo, there was an initiative because it's almost impossible for a physician to get a physician's appointment that works for you. You know, 10 a.m. on a Thursday is not going to work for a surgeon very well. So there was a separate office that facilitated that, and that provided tremendous value. The Erlanger doctor's dining room, I will tell you that the person most critical to my success and ameliorating my bacon deficiency every morning is Kim, who not only provides me fresh cooked bacon, but also a smile, and it's a place where we can meet with colleagues. Dr. Panda was involved in a survey about residents and faculty here. And the interesting thing is that people are afraid of doing surveys because you're afraid that people will suggest that you solve COVID or you fix the United States healthcare system. But really, our survey didn't find that. People asked for small, doable initiatives, like the residents want snackies on call. That seems doable. The residents would like communication strategies to and from nursing and attendings. That's also doable. Other physician or institutional strategies are making the workplace more friendly in terms of customizable options, encouragement of and by physician leaderships, espousing fairness and transparency, and espousing work efficiency and mentorship programs. You as a resident may say, well, what can I do? Well, as a physician, you are a leader. You may be a leader with the nursing staff. You may be the leader of the interns or the medical students. And I think that it's helpful to remind the team of the why, as the other speakers have talked about. And if there's a why we can all buy into, then it's not just a rat race. Other strategies, manipulating your environment, knowing your triggers and develop strategies to avoid those. So for example, many people, especially now, are triggered by watching the news or the media. Avoid that. Toxic people and situations. I think one of the strategies with that is develop a sense of humor or sympathy with those individuals. Gosh, I'm really glad I don't live in their skin. I'm really glad I don't have to go home with them. That's a sense of gratitude. My personal trigger is meetings that can be emails, and I do almost everything I can do to avoid those, and sometimes I can't. Knowing yourself and how you unwind. If you're an introvert, you need some time alone, and you can set those clear boundaries. If you're an extrovert, then you thrive on dealing with people, and you may need that interaction. Be creative about manipulating your environment and who you choose to surround yourself, and manipulate the sphere that you live in. Uphold your values. If it's outside of your sphere, there's a song about that. Let it go. Although you can exert some, perhaps minimal changes about the environment, as other speakers have talked about, you can choose how you react to it. You can choose what you take home when you think about it. You can choose to leave that environment, and you may choose not to, but simply recognizing that you have that choice and you are not exercising that choice to leave it may be really helpful. You can choose to fight for what's good and true and right. We're professionals. We took an oath about what that is, and upholding those principles can really remind us of the why we do this. And lastly, especially for the residents, have a life, have a passion, and have a hobby, and make sure that those aren't work. Thank you.
Thank you all very much. I think what a wealth of information here and practical suggestions for us. I think you've given us a lot to think about. And as you all said, I mean, we could spend an hour on each one of these, but they've really sparked, at least in me, a lot of interest in carrying some of the ideas given forward. I'd like to open it up to any questions from the audience.
Can I make a comment? First, I'd like to applaud UT Chattanooga for putting on, Julie put on a good program, and applaud the university for addressing these types of situations. I have a question for Scott. Scott, you said there was a half-day mindfulness program that you did is that something that Hopkins did, or is that a national program, or what was that?
So this took a lot of work, and I want to say it was when Julie and I were co-chairs of the ethics committee. I want to say it was a conversation that we had, telling her as I was working to help create this was what led to us making this panel, if I'm remembering correctly. But as the residency program director, I have to create a half-day retreat for our department, and I kind of survey the faculty and residents and ask them, what do you want to talk about this year? Some years it's medical topics, but a couple of years ago they said, we want to talk about burnout. And I thought, okay, let's talk about that, but maybe talk about it in a more constructive, because talks about burnout can be sort of downwards if you're only talking about what's bad. Johns Hopkins has a group called the Faculty and Staff Assistance Program, FASAP, which is clinical psychologists and social workers. That's sort of our group of, they have a 24-hour number. If you need help now, you can get it, as well as more regularly scheduled daytime services. And I met with one of their staff, and she was such a wonderful resource about this, and sort of worked with her to create this program. So this was actually specifically for our department. I'm happy to share her contact info. I believe she's still at the FASAP office. And to give credit, she did most of the work. I kind of facilitated and helped shape it for what do plastic surgeons want to hear about. But this was mostly her wisdom, guidance, let's include these resources. And then, okay, how do you keep a room full of surgeons engaged for 4 hours when we're used to running in 20 places and answering pagers and stuff? So that's where that came from. It was a half-day thing, department specific.
Thank you. And I think that is a reminder, please, in the chat, if you don't mind, there was an email that had been sent out as to what would you all like to see at UT Chattanooga as part of this work as we move forward in the form of workshops or lectures. And I think listening to our speakers today may have sparked some ideas. So please feel free to put that in the chat box. I have a question. I was really struck by a statement. I think that might have been from either you, Scott, or Dr. Barron. Culture as a prescription. And I was wondering, how do we make that happen in a meaningful but not obvious way?
Right. There are, at UT Dell, they have there are several ways to achieve it. They have electives for the medical students, and the residents and fellows and attendings are involved in those as well. And so it becomes I think, a great way to address the burnout, a great way to address bullying, because you're all at different levels involved in these just electives. They can be at the end of the day. They can be not. They sometimes will be on weekends, but they try not to do that. They try to value the weekends, so they try to work them into the day. But they will be sometimes it'll be a lecture from the curator of the Blanton Museum in the case of Austin. It'll be a poetry reading. It can be something as just basic as that we've all experienced, but long since let go of. And I think the point is to bring it back into our lives. We work often so hard that we just don't take the time. Everybody else, maybe in our families or our friends, are going to museums, watching documentaries, etc. And there are many, many roads to Rome. Music is a huge, huge one, and it's a big part of my life. And that exposure is unparalleled in what it does for us. So there are many roads to Rome there, but the key is developing them and having them be attainable. Just they can be a snippet, 15 minutes sometimes can, or just even sitting outside and lying in the grass and asking questions, one question to each other, anything like that.
Thank you. I think what I have found in my experience, it's like I think, the Gen X probably are the ones that need it most. The millennials are very receptive, and we've done a good job doing it with the students and the residents. And I think getting faculty to buy in tends to be a little bit more of an uphill battle in my experience, but thank you for that.
Sure. Yeah, and I guess one other thing I would say about that is, we already pre-COVID were technologically super saturated. And in the healthcare profession, now that we do everything on EMR, it's just overwhelming. So any capacity to unplug, to truly unplug for 15 minutes, for 30 minutes a day has been shown in studies to be tremendously beneficial.
Thank you.
Yeah, I don't know if you guys have gotten into the scribes there, but I'm just saying for me, it's been life-changing. I used to spend 5, 6, 7 hours on a weekend dictating my charts and signing off on them. Now, with the very efficient scribe, I'm done at the end of clinic. So, I mean, and Julie, I know you talked about the dot phrases, but, as you get a little bit older, you're not quite as facile on the computer, right? And it takes longer and longer. I mean, it'll probably take me longer to figure out how to do the dot phrases. But the scribes have really been a life-changing thing for us. And we're looking into it right now to see if it's actually, one, if they pay for themselves, and two, if they actually increase the billings and all that for us. So we're looking at that right now. But in terms of just EMRs, it's a game changer.
I think thank you all also for really emphasizing self-care, and also the fact that it is really something that is vital and valuable and not selfish. Just wanted to remind everybody in the audience about the oath to self-care and well-being that we do with the students and recently with some of the residents. And I think it's something that we all need to sort of at least keep in our minds and remind ourselves. That's while the Hippocratic Oath was timeless, I think it was written in a different time, and we really need to append that just like it was done with the Declaration of Geneva. So we can send that out. But Julie, anything else?
No, thank you, Dr. Panda, and thank you all for your attention. Hopefully this was not a meeting that could have been an email for you and everyone else. Thank you all to our speakers. Some of them got up very early because of the time change. Again, Lissy, Dawn, Alton, and Scott, thank you again. And perhaps Dr. Panda, we should conclude the meeting today.
Yes, I also want to echo my thanks to the speakers. I think this has been a very, very informative session, and hopefully we will definitely be sending the recording out to everybody. There was a question in the chat box, And I hope that we can continue this discussion with our esteemed guests as we move forward and plan events on our campus. I think in the spirit of one of the suggestions that was made in the talk about the power of gratitude, something that I have done before and I'd like to do perhaps today is in the chat box, take time to just offer gratitude to somebody that you have. You can offer it privately or publicly as you log off. And with that, I just want to thank Kim Judd again for organizing and making this happen. She does a lot of leg pulling at the back to make sure everything is on time and organized. So thank you, Kim. And also want to remind everybody about tomorrow's grand rounds, which is a combined grand rounds, looking at a personal journey of recovery from substance abuse by Dr. Stephen Lloyd, which I'm sure would also be a very valuable discussion organized by Dr. Court and his colleagues from the CLEAR subcommittee. So thank you all again and wish you all a very good day and rest of the week. And Dr. Adams, thank you once again.
Thanks, Dr. Panda.